Good evening and welcome to Above and Beyond Cancer's Cancer Education Series. Tonight we have a real treat. Our founder, Dr. Dick Deming, is going to talk to us about cancer treatments in the COVID era. It's my distinct pleasure to turn the program over to Dr. Dick Deming. Dr. Deming?
Hey, Chris. Thanks a lot. Welcome, everyone. Thanks for joining us this evening. And as Chris said, my topic tonight is cancer care in the COVID crisis. So let me bring up my slides here. And there we go. So we're going to talk about cancer care during the COVID-19 pandemic. But before we do that, let's do a little reflection, kind of put us in a good mood. I hope that you guys have been enjoying this incredible weather and getting outside in nature. Nature has the power to heal, and it's great to be outdoors. It's great for social distancing. It's great for fresh air, and it's good for the mind, body, and the spirit. I'd like to share as a reflection a poem by Wendell Berry, and the poem is "The Peace of Wild Things." When despair for the world grows in me, and I wake in the night at the least sound, in fear of what my life and my children's lives might be, I go and lie down where the wood drake rests in his beauty on the water and the great heron feeds. I come into the peace of wild things, who do not tax their lives with forethought of grief. I come into the presence of still water, and I feel above me the day-blind stars waiting with their light. For a time, I rest in the grace of the world, and I am free. And no matter how crazy the world gets, just remember, all you have to do is go outside, find some solitude in nature, and find the peace of wild things. And did you guys see the rainbow this morning? Boy, when I was driving into work this morning about 6:30, there was this huge rainbow, also reminding us of the peace of nature. So we're going to talk about cancer care during the COVID pandemic. And we're going to focus on 5 things this evening. First, we're going to focus on a survey that the American Cancer Society Cancer Action Network did of cancer survivors, and this was done in April. Then second, we're going to review the results of the IQVIA Institute for Health Data Sciences on a survey that they did looking at the shifts in healthcare demand, delivery, and care in the COVID-19 era. Then we're going to look at some of the changing practices in medicine that we've seen. We're going to look at the impact the COVID pandemic has had on cancer research. And then finally, we're going to try to come to some understanding of how do we balance risk and benefit. You know, everything in life is a balance. It's not about overabundance of caution, and it's not about throwing caution to the wind. It's about balancing risks and benefits based on the science. So first of all, we're going to focus on the survey that was done by the American Cancer Society Cancer Action Network. And this was a survey that they conducted of 1,200 cancer patients and survivors during a 2-week period. And it's going to focus on the delay that has taken place in cancer treatment. It's going to look at the change in the financial condition that individuals have experienced and the effect on mental and emotional health. The difficulties that cancer patients and survivors encounter accessing and affording health care have increased dramatically during the COVID crisis and continues. Most alarmingly, 79% of patients in active treatment for their cancer reported a delay to their health care. and that was up 27% from the previous study, including 17% of patients who had a delay in their active treatment. Delays were most common among patients who were not currently in active treatment. 78% of them reported a delay, including delay in care related to their cancer, as well as their regular and preventive care and care for ongoing healthcare issues. 1/5 of all cancer patients and survivors reported a concern that their cancer would be growing or returning due to the challenges they faced in obtaining health care. Second, nearly half, or 46% of cancer patients and survivors, reported a change in their financial situation as a result of the COVID-19 pandemic that affected their ability to pay for the care, and that was up 38% since the initial study in April. 23% worried about losing health insurance. 27% of those who are employer-sponsored plans expressed a concern. And beyond paying for the health care, nearly a third of cancer patients and survivors worried about their ability to afford basic household expenses, such as rent, mortgage, and food. And third, nearly a half, 48% of cancer patients reported that their experience as a cancer patient or survivor during the COVID-19 pandemic is affecting their mental and emotional health. So let's dive into it a little bit more deeply. So this is the healthcare impact of COVID-19. And you can see 87% had some type of impact on their health care. 80% had an impact on their regular care or their preventive care. 62% experienced an impact on their actual cancer care, and 68% had an impact on the care for other chronic conditions. When you look at care delayed, 78% experienced some delay in care. 65% experienced a delay in their regular or preventive care. 37% actually experienced a delay in their active cancer treatment. And 41% experienced a delay in the care for other chronic conditions. And when we look at the financial impact, again, nearly 50% of patients had a financial impact, and 40% found that this was difficult to find food, 19% having difficulty affording food, 81% were having difficulty finding cleaning supplies and other products they needed, and 29% were having difficulty affording those products. And when it came to PPE, 70% were having difficulty finding appropriate PPE, and 29% were having difficulty affording PPE. Next, we're going to talk a little bit about the shifts in the healthcare demand, delivery, and care that has happened during this COVID pandemic. And this is a survey that was done by IQVIA, an Institute for Human Data Science. When we look at the impact that health services has experienced because of the COVID crisis, we find that the adoption of restricted movement across most of the states resulted in a 70 to 80% reduction in the number of patient visits to their doctor's offices. And that included 76% decline in patients presenting with asymptomatic conditions. On the bright side, if there is a bright side, is that during this time, we've been talking about doing telehealth for a long time, but there have always been significant barriers, including insurance companies' willingness to pay for that. During the pandemic, we've seen a significant increase in the use of telemedicine services. Overall, though, there was a reduction in 70% of healthcare interactions. When the pandemic started, I remember actually thinking to myself, boy, I am blessed that I am involved in a profession that is going to be in significant need, and it's not going to be affected in terms of my livelihood and what I'm doing on a day-to-day basis because I'm in healthcare. It's been very surprising to see a significant reduction in healthcare use. And we're even seeing healthcare systems having a reduction in force, even a reduction in physicians because of the decline in the use of healthcare that we're experiencing over the pandemic. Some of it was healthcare systems saying, you know, please delay anything that's not essential. But part of it has also been fear on the part of patients that going to their doctor might expose them to the risk of catching the virus. If we look at care for cancer patients, we've seen that oncologists relatively quickly started adapting the level of patient interaction based on guidelines provided by professional societies and prioritized reducing their capacity to see and treat patients depending on the tumor type and the progression of the cancer. Changes in the number of patients' interactions with oncologists since February, before the pandemic was realized, based on medical and pharmacy claims, that there was a decline on average by 20% based on tumor types. It wasn't universal across the board. Patients with tumor types that are typically considered aggressive, such as head and neck cancer and pancreatic cancer, ovarian cancer, did not decline as much as cancers that are sometimes seen as less aggressive, like prostate cancer and breast cancer. We're also going to see that there was a very significant decrease in cancer screenings that were done in March, April, and May. And we're going to see the impact that the reduction in cancer screenings may have on cancer incidence and the stage at the presentation of cancers over the next year. This slide shows some of the tumors that were prioritized where there was not a reduction in patient-doctor interactions, and those cancers include head and neck cancer, lung cancer, gastrointestinal cancer, pancreatic cancer, ovarian cancer, and liver cancer. On the far right, the reprioritized tumor, those are the types of cancers in which there were fewer doctor-patient interactions, presumably because the doctors were delaying some of the care for these less aggressive types of cancer, and included in those were prostate cancer, skin cancer, and some blood disorders. And then in the middle were the intermediate tumors where there wasn't a significant change, and that included breast cancer and lymphomas, melanoma. This is a slide that demonstrates the significant decrease in cancer screening that has been done during the early part of the pandemic. So in terms of mammograms, and again, this is screening mammograms. So what is a screening mammogram? A screening mammogram is a mammogram that's done on a woman who has no history of breast cancer and no symptoms of breast cancer. So that would be a screening mammogram. An 87% reduction in screening mammograms during the early part of the pandemic. An 83% reduction in pap smears, a 90% reduction in colonoscopies, a 39% reduction in CAT scans, and that would include lung cancer screening CAT scans, and a 60% reduction in the PSA, that's the prostate-specific antigen blood test. If we look at the impact that this may have on cancer incidence and the presentation of cancers, so a lot across the top are the various screenings: breast cancer, cervical cancer, colorectal cancer, lung cancer, and prostate cancer. And the first line is the annual number of screenings that are done for breast cancer, 42 million, cervical cancer, 79 million, colorectal, 9.5 million, 700,000 lung cancer screening tests, and 4.3 million prostate cancer screenings. Because of COVID, you can see the reduction that that has been calculated through the through the beginning of June. So 69% reduction, 67, 72, 30% reduction, 48% reduction. What that is going to result in, and that's the bottom line in red, is a delay in the diagnosis of cancers. 36,000 fewer breast cancers will be diagnosed initially because of the reduction in doing screening mammography. If you add all of those up across the bottom line, it's about 80,000 fewer diagnoses of cancer. So if all you're going to look at is the statistics for the number of cancers diagnosed in the year 2020, you're going to see that there's probably going to be a reduction in the number of diagnoses. Now, those cancers, it's not that those cancers don't exist. It's really going to be a delay in the diagnosis of those cancers. And what we're really concerned about is that delaying the diagnosis of cancer will likely result in an increased stage when those cancers are diagnosed. Unless we get right back at screening at the same rate we were before, we're going to find a delay in the diagnosis of cancer, and that delay will result in patients being diagnosed with a higher stage, and that will result in more patients dying of cancer as a result of the loss of screening. Next, let's talk a bit about cancer research. As you know, we have made tremendous progress in the fight against cancer in the last 30 years. Significant reduction in the number of individuals that are dying of cancer. And that is attributable to several things. Number one, it's increased screening so that we're finding cancers at an earlier stage when the cure rate is much higher. Second, it's preventing cancers, and a large part of prevention of cancer has come from a reduction in tobacco use over the last 30 years. But third, a lot of the improvement in the survival of cancer patients over the last 30 years has been because of better treatment, and better treatment is a direct result of cancer research. So one of the things that we're worried about is that there's been a significant decrease in cancer research as a result of the COVID-19. Why would there be a decrease in cancer research? Well, one, patients are reluctant to take on more aggressive treatments if they fear that it will affect their immune system and perhaps expose them to the virus. Second, cancer doctors are reluctant to initiate new cancer trials during this time because energies have been placed elsewhere, and there's also a concern that exposing more patients to more chemotherapy drugs would perhaps make them more vulnerable. So we've seen that in the United States and Europe, 60% and 86% of institutions, respectively, were enrolling new patients into clinical trials at a significantly reduced rate. So that is one impact that COVID-19 has on cancer research. On the other hand, during the COVID-19, we actually mounted a clinical trial actually a research study where any patient who is diagnosed with COVID-19 while undergoing cancer treatment has been enrolled in a study where their blood has been drawn, and we're going to look at the impact that the COVID-19 infection had on their cancer care. So it's not a randomized prospective study. It's not a study that's looking at treating the COVID virus, but it's looking at how did patients who got the COVID virus while they had cancer, how did the COVID infection impact their cancer care and impact the outcome of their research, of their treatment. This is a slide that I borrowed from the American Cancer Society Cancer Action Network. And the tagline here is during COVID-19, cancer hasn't stopped, so neither have we. And that has been a motto that has kept me going during the COVID-19 as we continued to care for patients. I would say that at Mercy One Cancer Center, we did not have a significant change in the way that we saw our follow-up patients and in the way in which we continued to see and work up new patients. I believe that the cancer diagnosis is a diagnosis that still needed to be attended to even during the COVID-19 crisis. And even patients who might have, a very favorable diagnosis where delay of treatment may not significantly affect the outcome, it certainly affects the mental health of a patient who's just been diagnosed with cancer and then told, well, but your cancer really isn't that bad, so we're just going to delay things by a few months until things get under control. So fortunately, we have the resources here in Iowa to continue to see patients and work them up and proceed on with treatment without significant delay. The way in which patients have received their care, though, has changed. So here I am. Let me grab my gear. So if you were seeing me in my clinic in the last few months, you would see me looking like this. So I've got my face mask on and I've got a face shield on, and my patients have a face mask on. And as you have all experienced, we speak a bit muffled and we hear a little bit more difficulty. But more importantly, it is difficult to express empathy and compassion as effectively with our face covered up. So I would tell you that I cheat a lot and that I will walk in dressed like you just saw me. But then after greeting my patient, I'll sit 6 feet away and I'll lower the face mask, but keep the face shield on. And I feel that I'm much more effective in communicating. Most of what we as cancer doctors do is communicate. Yes, we do a physical examination, but those of you who are cancer survivors know that the physical examination really only takes a couple of minutes, and I might have an hour interaction with my patients, especially on the first day, where I'm showing them their x-rays, we're talking about the pathology report, we're going over their history, we're talking about what's important to them, we're talking about all the options, we're talking about prognosis, and we're creating a plan. And all of that is really communication. And the ability to communicate effectively with empathy and compassion really requires the use of your whole face. So that's been one way in which COVID-19 has affected cancer care. A second way in which COVID-19 has affected cancer care has been in who patients have been able to bring with them. With the virus, there's been all sorts of restrictions that have been placed on interactions that happen in the doctor's office. We often will tell patients to either come alone or just bring one person with them. I mean, before we had any restrictions, it would be very common that a patient might bring many family members with them, and we would accommodate everyone. I can tell you, we still have the ability, with compassionate exceptions, to bring patients and family members in. And I think it's particularly important for those who have uh, difficulty hearing or difficulty comprehending. And the classic situation might be an elderly patient whose spouse is also elderly. And when you say, okay, you can only bring one person with you. Well, does the elderly person who has cancer bring their elderly spouse or a younger child? And I believe strongly that having your spouse there and also having a younger caregiver who has better hearing and can take notes and help communicate, really, that the benefit of having those people in the room outweigh the small, not zero, but the small increased risk that we might be exposing someone to the virus. Also, I'm a radiation oncologist. I'm not a medical oncologist, but many patients who get chemotherapy in the outpatient setting are in the chemotherapy suite for hours, and they might traditionally have brought a friend or a family member with them. And I know that many of the infusion centers had limited the number of people that could be present. The same thing goes for the hospital. You know, as the number of COVID patients has gone up and down, the rules have changed over time. Can anybody be on the cancer floor except the patient? Can it only be one person? How many can be there? How do you make exceptions, compassionate exceptions? I think that we have done a good job of, adhering to the protocols of PPE, protective gear, social distancing, but yet balance that with compassion for those patients who are in the hospital who might have difficulty comprehending, for those who are having emotional difficulty and are experiencing significant emotional turmoil, and having someone there with them is the right thing to do. So those are some of the ways that the COVID-19 has affected the normal delivery of cancer care. What else do cancer patients need to know about COVID-19? So number one, as you've noticed, the rules are always changing. We believe in evidence-based medicine, and that means we believe in following good science. But COVID-19 is new, science is evolving. How we manage individuals that, number one, have the virus, or number two, have been exposed to someone who had the virus, or number three, that have had the virus but now are now asymptomatic. That has changed since the beginning, and that will change while we're going through this. Avoiding being exposed to the COVID-19 if you're immunosuppressed is an important thing to do. There is no doubt that those individuals who are immunosuppressed are at greater risk for having a serious illness if they catch COVID-19. So we can't just proceed as normal. We realize that there are times where delaying treatment may be in a patient's best interest. We're still trying to gather more and more data. Obviously, we don't want to delay treatment to the extent that the increased risk of dying of cancer exceeds the risk of developing the virus. So those protocols and those recommendations will be consistently changing. Second, when is care considered elective and can be delayed? And when is the risk of catching the virus going into the hospital not that much different than staying at home, and we can proceed with care? That information is continuing to evolve as we are in the midst of the pandemic, continuing to collect the data, analyze the data, and learn when we can proceed with the right amount of caution. Finally, I want to talk about cancer screening. So you saw that very quickly we had a very significant reduction in the amount of cancer screening. So for example, in the first month, we stopped doing screening mammography. When do we come back to doing things as normal? And at our institution, we are now back to doing screening mammography. We're back to doing CAT scan screening for patients at high risk for lung cancer. And we're back to doing colonoscopy as screening for colorectal cancer and pap smears. When do you, as the public, feel comfortable coming into the doctor's office to be screened? So it's not only when do we as docs feel comfortable resuming screening, but when do you as patients feel comfortable? And this is this balance that I talked about between the overabundance of caution and throwing caution to the wind. What is the middle path? Everyone has a different sense of what I will call risk aversion. The way we live our lives, some of us take on more risks in our lives than others. And a lot of that is based on philosophy, not on hard science. So I would say that each and every one of you has a role to play in determining when you'll get back to going to the doctor for your normal visits and when you'll begin doing cancer screening. The risk that you will catch the COVID virus, have a significant illness, and or die of the COVID virus is extremely small in going to your doctor's office. It's not zero, but it's extremely small. Your risk of dying by driving fast on an interstate is also small, but not zero. And many things that we do in life are risky. If you are a cigarette smoker and you choose to continue to smoke, but yet you don't go to the doctor because you're afraid of catching COVID, that doesn't fit the science of risk. Your risk to your health by smoking is considerably greater than the risk that you'll catch the COVID virus if you go to see the doctor. So I'm not telling everybody what to do, but I'm asking everyone to consider that living life on earth is not risk-free and never will be, and to try to put risks in perspective, to wear a face mask, social distance, do the things that will help reduce the risk, but that there are some things that are of such benefit that it's worth the small increased risk. And from my perspective, the benefit of cancer prevention, the benefit of cancer screening, the benefit of seeing doctors for health problems, the benefit of undergoing cancer treatment is worth the small risk that you may expose yourself to by going to see your doctor. So again, we can't talk about risks without talking about benefits. And how do you try to balance risks and benefits? here's a guy that is social distancing. So he's probably not putting himself at great risk for the virus there in the Himalayas by himself. Clearly, no one's within 6 feet of him. And I think even if the photographer sneezed on a windy Himalayan day like that, it's not going to carry the virus to him. At this point, I'd like to open it up to questions. So let's see. Chris, I'm going to stop sharing my slides because then I can access any questions that might be posed. So right now, those of you who are participating via Zoom aren't able to ask. And here I am still with my face mask. Sorry about that.
Occupational hazard, I'm sure.
So if anybody has any questions, or Chris, if you have any questions.
Well, I'll relay any questions I find, but the two that came to my mind was, one, were there any specific changes in the way chemotherapy was delivered? Like, was there ever more of a home situation or where chemo was delivered to people in their own homes? Was that ever a thought? Or
Yeah, so I'll answer that first by saying that yes. For example, many patients are on oral chemotherapy. So if you used to go into your chemotherapy doctor's office just to pick up the bottle of pills, that was no longer necessary, and a way was found to make sure that the pills got to the home via delivery system or mail rather than going in. Second, there's not a lot of chemotherapy, intravenous chemotherapy, that is given at home. The most common intravenous chemotherapy that's given at home is a type of medicine called 5-FU that is sometimes put into a little motorized pump that you wear in a fanny pack and that you pick up and is delivered. There weren't a lot of changes in the regimens or a lot of home infusion that was done here in Des Moines. I would say that the change came in how many people that could go with you to the infusion center. Certainly the way that everyone was wearing masks and social distancing, and a lot more use of disinfectants in the chair and the equipment and the computers and the remote controls and everything that you come in contact with.
what about any drug shortages because of COVID-19? Were there any cancer drugs that somehow got rightly or wrongly identified as being helpful in the battle against COVID that became a shortage for cancer patients?
Good question. I'm not aware of any oncology drugs that there was a shortage of because of the COVID-19.
Or have there been any decreases in the medications available because the pharmaceutical companies have taken their eye off cancer because they're so focused on finding a
I'm not aware of
vaccine?
that. I mean, periodically, even before COVID, there were occasionally certain medications that there was a shortage of, but to my knowledge, I'm not aware that there's been a transition to the production of different medicines that's resulted in a shortage of medications for cancer patients. I'd be interested, anyone listening, if you want to, instead of ask a question, just share maybe the impact COVID-19 has had on your cancer care. Did anyone who's in the audience have your treatment delayed, have scans delayed, have surgery delayed because of COVID-19? What other ways was your care affected? And were there any bright spots? Was there anything that happened in the change in care that you thought represented an improvement?
At Mercy One Cancer Center, are you able to see as many patients as you were before the pandemic, or because they have to wait in their car and then be called in and they can't really wait in the waiting room?
Yes, you're right that the policies and procedures and the even, taking everyone's temperature, asking this standard set of questions that help delineate whether they've been exposed to risk does slow the throughput, if you will. I would say that that has been a slight decrease in the number. We also offer video telemedicine visits to patients who don't who feel that it's too risky to come in. So yes, there was a bit of a downturn. As you saw, overall, there was a 70% reduction. We certainly didn't see anything like that. I would say that in my clinic in radiation oncology, if anything, it was more like a 10% reduction.
That's good.
So we're just waiting for any other questions. You know,
It's unrelated to care. It was beneficial that this person's husband was working from home during the pandemic. I hadn't thought of that. So this particular patient wasn't home all alone during recuperation.
yeah. You know, being alone certainly reduces your risk to being exposed to the virus. I would say there is benefit, however, to social engagement. So again, you can't talk about benefits without talking about risks and what's the best way. Some people have become isolated, and unfortunately, some people who suffer from isolation have been isolated more. But you're right, the workplace is going to change forever. There are many, many people that are working at home, and businesses are thinking, gosh, maybe we don't need as much office space because some people, the job they do seems to be not adversely affected by being at home. So I appreciate the questions and the remarks that have come. Looks
There's
like one
another
more
one.
question just popped in. If you
you've
had it, go ahead, Chris.
if you've had a history of cancer and now considered cured, would you be considered an underlying condition that put at greater risk for COVID?
That's a great question. I would say no, you're not if enough time has gone by. And then the question is, what's enough time?
I was just going to ask that.
So I would say, in terms of the effect that having cancer has on making you at greater risk for number one, acquiring COVID, and number two, having a more serious illness, we think it's primarily related to the immunosuppression, and that the immunosuppressive effects of chemotherapy and radiation therapy probably, I would say, if you're 6 months to a year out from your treatment, you're probably not at greater risk. But there are other things that put you at greater risk. So, for example, obesity puts you at greater risk of having a serious illness if you acquire the COVID virus. And that's probably true of many, many, many other conditions. But that is one piece of evidence that has come out, is that, it's not just being over 65, it's not just being immunosuppressed, but being less healthy, and specifically being obese. Individuals who are obese, who get COVID, fare more poorly and have a greater risk of dying of COVID than individuals of normal body weight. Well, I think we'll bring it to a close this evening. Let me end by reminding everyone to stay safe. And staying safe means wearing proper protection, remaining socially distanced, and uh, covering your mouth and washing your hands often. We often forget the washing your hand part. Washing your hands often is really, really important. But it's also important to engage when it's safe, to see the doctor when you're having a problem, to continue to get your cancer screenings, and to appropriately weigh the risks and benefits. We still need to live our lives, and there is risk in living our lives, and finding the sort of the middle path. I'm going to end with a bit of a reflection, and this is a tribute to the late John Lewis, the U.S. representative from Georgia who was instrumental in the civil rights movement. And we'll end with a quotation from John Lewis. "Freedom is not a state, it's an act. It's not some enchanted garden perched high on a distant plateau where we can finally sit down and rest. Freedom is the continuous action we all must take, and each generation must do its part to create an even more fair and a more just society." So with that, we'll end our session tonight. Please join us next week. Allison Pete, who is a certified mindfulness stress reduction instructor, is going to give a talk next week on mindfulness for stress reduction. The following Wednesday, August 19th, Greg Fuqua, who's a licensed mental health counselor, is going to talk about art as therapy for cancer survivors. And then the final Wednesday of August will be Alex Kennison, mental health counselor, talking about setting healthy boundaries with our loved ones. So that's coming up the remainder of our Wednesdays for our cancer education series. Thanks for joining us. This talk will be available online at the aboveandbeyondcancer.org website. Thanks for joining us.
Thanks, Dr. Deming.
Bye-bye.